So, Seemaji, can we go live now?
Yes, sir. Just allow me
Is
1 minute.
my PowerPoint visible?
Yes, sir. Yes, sir. Your PowerPoint is
Okay,
visible.
sure. Okay. So what I'm going to
So,
do is I'm going to, after my presentation, I'm going
yes,
to
Seemaji, can we go?
disconnect from this
So
and
we
go
are
on
live.
my phone, and I'll answer my questions on the phone from my OPD room. So I will not, my camera will not be on. Okay, please don't mind during the Q&A. I
Sure,
won't be
sure,
on.
sure, sure, sir. Sure, sir. Sure, sir. So I'll just do a brief introduction. Welcome to 36th NephroCon webinar. We do this religiously every month on a Friday, 7:30 to 8:30, and we try to discuss very core issues of clinical nephrology. And we try to bring in the most brilliant minds across the country. And we are really delighted to have Dr. Santosh Varghese sir, who is a professor of nephrology, needs no introduction. But to me, he is an educator. And you will realize it in coming 30 minutes. As esteemed panelists, we have Dr. Shrikant Gundlapalli, our friend, our guide from Hyderabad. We have learned a lot from him. And we have Dr. Nagesh Aghor, who is a very accomplished nephrologist from North Maharashtra, pioneering critical care nephrology, advanced transplantations in Nashik. So, welcome you all. And without any further delay, I request Dr. Santosh Varghese sir to start his lecture. Thank you, sir.
Thank you very much for your very kind introduction. I hope my brain will not be very fuzzy as I speak, but God willing, it be all right. So the topic given is hyponatremia, something very close to my heart, and I sometimes obsess about it. Is as our residents will say, the topic given is too slow, too fast, too late. So giving very clear guideline as to the different problems that we are likely to make and how to approach them. So, without much ado, we'll start, and I'll try to keep my presentation lucid and taking as time as required. So, two neurological emergencies to be careful about when we're dealing with hyponatremia is one, as we know, the hyponatremic encephalopathy, or when the sodium is too low and we haven't been able to correct it properly. This happens usually in the acute hyponatremic state, where the tonicity is low and there is water shifting to the brain cells, cerebral edema, raised intracranial pressure, and herniation, which can be catastrophic. The risk factors are post-operative and young women and those on ecstasy, other things like marathon runners. I have some clinical cases that we can look at. And what often forgotten is children who can have edema because their intracranial space is quite small, and the treatment is, if delayed, can cause permanent damage or death. So we need to give a 3% sodium chloride stat as soon as we see. And the other one is osmotic demyelination, where we've corrected too fast. In chronic hyponatremia, the brain adapts by losing its organic osmolytes. And when there is rapid correction, the extracellular osmolality rises faster than the brain can restore the osmolytes and equilibrate the balance. As a result, there is further loss of fluid, and the brain cells can shrink and rupture of myelin sheaths, etc. And this can cause demyelination. So clinically, this presentation, as we have studied in our MD days, is as an initial improvement. Then 2 to 6 days later, there is a lock-in syndrome with pontine affectation, with dysarthria, dysphagia, quadriplegia, locked-in syndrome, and finally death. And in many cases, it's irreversible. Prevention is the only effective treatment. Now, the treatment for the first emergency or prevention of the first emergency can lead to the second emergency if you apply to the wrong patient. Therefore, it's very important for us to gauge and treat properly. That is, if in acute hyponatremia of the brain has not been adapted, fast correction is safe. But it's chronic hyponatremia, if the brain is gone to equilibrium, then mandatory limits of our corrections, as we know and as you will see, is mandatory to prevent the osmotic demyelination. Having said that, let's go on to some basics that we need to remind ourselves. The one of them is osmolality, and the other word is tonicity. Now, osmolality is a concentration of all dissolved particles. It's measured, it's a measured value, and it includes sodium salts, glucose, urea, ethanol, mannitol, everything dissolved in plasma is osmolality. And the normal measured osmolality we know is 275 to 95. The tonicity, on the other hand, is a slightly different term, which is effective osmolality. That is only particles that cannot equilibrate across cell membranes, that cannot pass freely across cell membranes. That is, this is what drives the water movements between the intracellular, extracellular compartments. So, this is important for us to remember. Sodium and its anions, glucose when it's above normal, these are effective osmoles. And ineffective osmoles are the substances like urea, ethanol, methanol. These equilibrate freely across membranes. They raise the osmolality but do not drive water membrane and water movement across the membrane, and therefore do not cause cerebral edema. Okay, so this is important to remember these two concepts. And the effective osmolality is 2 times the sodium concentration plus glucose millimoles. So without hyperglycemia, it's roughly 2 times the serum concentration. 2 times the serum concentration. So let's take an example where we might make a mistake. A patient's got a sodium of 118, but the urea is high, and therefore the measured osmolality is normal, but the tonicity is less, and that can cause cerebral edema. So you have a patient who's got hyponatremia with high urea, and but you have normal osmolality but low tonicity. The correction for hyperglycemia, as we've read in way back in Harrison's, of adding 2.4 millimoles of sodium for every 100 milligrams of glucose in rise above 100 milligrams, or 5.5 millimoles of liter of glucose. Okay, now coming to some equations. The first equation is the Elderman equation, where it is sodium, serum sodium is equivalent to the exchangeable sodium plus exchangeable water divided by total body water. This concept of how the sodium is dependent on the exchangeable sodium and the exchangeable potassium and the numerator, and the total body water in the denominator is very important for us to understand conceptually why hyponatremia develops and how to treat. So in the numerator, if there is a loss of sodium along with hypovolemia, or a loss of potassium in hypokalemia, you have a loss in the, you have hyponatremia resulting. And in the denominator, if there's an increase in the denominator of gain of free water, like water retention, excess IV hypotonic fluids, you have a hyponatremia. So this concept is very important. It took me a long time for me to understand that it is often the denominator change that makes a change in the serum sodium, increase in the total body water, and not a sodium deficiency that leads to hyponatremia. Okay, so for this reason, we need to be able to have an estimate of the total body water. Measurement is very difficult and probably not important. So we know measures are zero point 0.6 is roughly the usual one. We have to make corrections for older age group and women, and for older women, so about zero point 0.5, zero point 0.5, 0.45. The other important cation which is commonly missed, and I keep ranting about it to our registrars, is potassium. The potassium replacement raises serum sodium. This we'll discuss potassium when you look at the urine lights as well, another place. So here potassium is in the numerator. So if potassium replacement also will raise the serum sodium. So if you have sodium 112 and potassium 2.4, if you give sodium correction, that also will raise the serum sodium by a bit, about 3 to 4. So if you fail to count the potassium correction during your hyponatremia correction, you are at risk of accidental overcorrection. And the total body water denominator needs to include volume of, I apologize for the typo there, excess water. That is increasing the effective total body water. So it's not just the ideal body weight, but it's you calculate the water edema as well. We look at this when we look at a patient population. The other important thing to consider is vasopressin. Now, almost all hyponatremia involves vasopressin activity in some way. There are two physiological stimuli which are important clinically. One is osmotic, when there's hypothalamic osmoreceptors sense an increase in tonicity, release AVP, and then there's water reabsorption. And hemodynamic, where the baroreceptors sense a decrease in the effective arterial blood volume and the AVP is released regardless of osmolality, and this overrides the osmotic trigger when it is severe. So hemodynamic decrease in the effective arterial blood volume causes an AVP release. This is why when you have a person who's got hypovolemia, even if the sodium loss is not too much in the volume, and the volume and the sodium have both been lost equally, there is still a increase in the AVP and there is hyponatremia. I hope that is clear. There's a question that I had when I was studying many years ago. I had this question that if somebody has a diarrhea and if you're able to measure the stool electrolytes and you think that is exactly the same as plasma, why does the serum sodium fall? And the answer is because the baroreceptors sense a decrease in the effective arterial blood volume and causes AVP release, and that triggers the hyponatremia. It's not because that there is sodium has been lost. Now there are very important non-osmotic, non-hemodynamic triggers, of which the most important one is pain. There are other things like anxiety, nausea, opiates, anesthesia, and drugs like SSRIs, cyclophosphamide, NSAIDs, and so on. Drug-induced SIAD. Uh, the important thing here I would like us to remember is that pain is a very important factor that we need to keep in mind for vasopressin release. So the principle of treatment is find the stimulus, remove it, and AVP switches off, and the kidney corrects the sodium spontaneously. Now, here the danger is that removal of stimulus can cause autocorrection or a rapid rise in sodium with AVP suppression and the kidneys pouring out dilute urine. If we have been diligent or remember what happens in emergency, when you have a volume depletion and we treat it, the sodium rise is actually much more rapid than we expect. This is the typical Viva question for the DM exam as to why does the sodium, I myself have asked it several times, why does the sodium rise rapidly even though we have not given that much of 3% saline correction? And we need to consider the syndrome of inappropriate diuresis where AVP released independent of osmolality and volume status and keep that as a diagnosis of exclusion. We need to exclude secondary adrenal insufficiency and drug-induced SIAD and hypothyroidism before considering this. Now, there are three ways we can look at hyponatremia. Three ways. We're not looking at we're looking at three different ways. One is based on biochemical severity, whether it's mild, less than 134 till 130, moderate, less than 130, 129 to 125, and profound is less than 125. And the European guideline uses the word profound, not severe, because that might confuse ourselves with severity of the symptoms. So the European guideline has changed the term or prefers the term profound for this. That's one. The second is based on duration, acute and chronic. Acute is less than 48 hours, that is documented to exist less than 48 hours, and chronic is more than or equal to 48 hours. In general, if we don't know the acute insult or we don't know that the acute insult has occurred, it is safer to assume that it is chronic. Always treat as chronic if the duration is unknown. And this 48 hours is because that's a time taken from brain to lose the organic osmolytes through slow adaptation. And the most important of the classifications is symptom severity. While biochemical severity is important, and profound less than 125 is definitely severe enough for profound enough hyponatremia. The symptom severity is most important for us to act. When there's just difficulty concentration or irritability, mild mood change due to mild or minimal symptoms. Moderate where there's nausea without vomiting, some confusion, headache, gait instability, and severe where there can be anything from vomiting to seizures or coma. Here, the symptom severity is what needs to capture attention first. And this patient, if you have a patient with seizures with a sodium of 128, it's not too bad. 128 is not bad. You need to give IV 3% saline. But if you have an alert patient of 106, this is not an emergency. We can get to the patient slowly. So we need to exclude the non-hypotonic hyponatremia first by excluding things like hyperglycemia, mannitol, pseudohyponatremia from increased lipase protein, which is mostly a textbook consideration now. Uh, but we need to still mention that in the exam when we are asked. The symptom severity, as I said, most important is where we bring in our armamentarium. Now, here is something which where we often or sometimes at least fail to do our due diligence and evaluation. Simultaneous with the serum electrolytes, we need to check uh, the urinary electrolytes. The urinary they all say different things. So the urinary osmolality reflects the vasopressin activity. The urine sodium reflects the renal sodium handling and the uh, effective arterial blood volume status. And the urinary potassium is often forgotten, but this is critical for the first equation and potassium correction planning. We'll come to this important. And this ratio of a urine to serum electrolyte ratio, that is urine sodium plus potassium divided by serum sodium, predicts whether fluid restriction will work. More about this in the next few slides. So, urine osmolality gives info about vasopressin. Less than 100 millimoles, it is maximally diluted urine. AVP is suppressed, and kidney is trying to correct the hyponatremia, like excess water intake, polydipsia, low solid diet, beer potomania. 100 to 300, where there's intermediate with partial AVP suppression or early recovery. More than 300, where the urine is concentrated, AVP is active, and kidney is retaining water. And more than 600 is very concentrated with severe SIAD or significant hypovolemia. Urine less than 100 in hyponatremia is not a kidney problem. It is a problem of excessive water intake, and the treatment is water restriction, not sodium supplementation. And the fall of urine osmolality during treatment signals the AVP switching off. And therefore, we need to check the serum sodium every hour to avoid autocorrection. The urine sodium and the ratio, the urine sodium less than 30, the kidney is avidly conserving sodium. More than 30, the kidney is losing sodium, like SIAD, diuretics, etc. The diuretics artificially raise the urine sodium. It is unreliable, and therefore, if the diuretics have been on board, things like fractionation of uric acid or urea is better at this. And this for which I spoke about earlier, the formula of urine sodium plus urine potassium divided by serum sodium. If it is less than zero point 0.5, the urine is dilute. So that means the uh, the urinary loss of sodium and potassium. So think of it like a tap being opened and the fluid is being lost in the urine. If the concentration of the urine is the same in sodium and potassium, is less than half that of the serum sodium, fluid restriction will be effective. If it is 0.5 to 1, fluid restriction may work, but we need to monitor and see. If it's more than 1, that is, if the urine sodium and potassium is more than the serum sodium, there is no way the fluid restriction will work. Okay, this is very important concept for us to understand. Think I'm running out a bit out of time. So the algorithm is to look at exclude hypotonic hyponatremia, look for symptoms, look at urine osmolality, look at urine sodium, and exclude SIAD before labeling SIAD. Now looking at the three things, too slow. Uh, so this is under treating acute hyponatremia where you need to give hypertonic saline. I'm going to rush through some of the slides. So This, if there's severe symptoms, a neurological emergency requiring immediate treatment, what we discussed earlier, what we discussed earlier about, so I won't repeat those. And this is post-operative patients, marathon runners, ecstasy, young children. These are people at risk. So the target is to raise the serum sodium slowly. So give small boluses of 3% saline over 20 minutes and then recheck. And initial correction of by increase by 4 to 6 is enough to stop herniation without causing ODS, and then we can slow down. At this point, we don't wait for urine results. We start treatment immediately if the patient has got symptoms. So let's just look at some of these things. So the correction dosing is the change in sodium. The delta sodium is sodium in the infusate minus the sodium in the serum divided by total body water plus 1, and 3% saline contains 513 or 50 we can take. Zero point 0.9 it contains 154 or 150, and D5W 5% dextrose contains nothing. So here we have a patient who's got 60-year-old woman who's got sodium of 116 with severe symptoms, and the total body water is 27.5. And to raise it by 5, you can calculate. I've shown the calculations here. You can give a few boluses, 2.5 boluses of 150, and to get the correction. The one caveat is the formula assumes no urine output. In reality, dilute urine is being produced, and the formula underestimates the net rise. So the actual rise can exceed the prediction. Actual rise can exceed the prediction. Okay, and correction also must be remembered. Where I told you AVP stimulus is suddenly removed, and you can a rapid rise of a sodium will happen, and concomitant potassium correction. So in this patient, you have got hyponatremia being overcorrected. If the patient got hypokalemia, you correct that as well. The correction may be more. And it's better that we use 2.2 ml per kg per bolus rather than fix 150 ml for very light or very heavy patients, and then make changes as and when required. Okay, so this is a minimum estimate, and we need to monitor sodium every 2 hours and be ready to stop as soon as possible. So here is a case of a patient. These are all cases I found reading in my reading. Patient who's got post-op hysterectomy had headache and nausea. So pre-op sodium was 140, post-op was 124 at 6 hours. And surgical colleagues were giving D5W, 5% dextrose at 125 ml per hour. Urine osmoles is 620, urine sodium is 68. Pain score was 8 by 10 on morphine. And the teens had mild hyponatremia, will monitor overnight. Then what happened is the mild hyponatremia, which the teen thought was benign, nothing was done until next morning where the sodium drops to 114. The errors made are 5% X was hypotonic. The post-operative state, morphine and pain, all of them are non-osmotic AVP stimuli, and the patient had a seizure, and then the patient was given isotonic saline, which is an error, which can cause desalination, and the sodium can cause further fall. So what would have been done was, if the sodium fall should have been documented and stop the D5W and correct the symptoms, give boluses, and switch to zero point 0.9 saline if necessary, treat the pain aggressively, monitor sodium, and so on. Okay, next patient, a 23-year-old woman collapses at the finishing line of a marathon with vomiting and confusion. She drank about 1.5 liter per hour of this electrolyte drink, which is hypotonic, for 6 hours. The sodium came to 118, and the duration of hyponatremia about 6 hours. Initially was 141. So patient, they said, give, because patient's dehydration, give 2 liters of 0.9% saline, and the sodium falls from 118 to 112 because of desalination physiology. And the exercise causes hyponatremia caused by overhydration, not dehydration. And the urine sodium meets the SIAD physiology, and therefore isotonic saline will worsen the sodium. The correction is to treat with hypertonic saline as the GCS improves, and then give the boluses as required. As required. Beer potomania, low solid hyponatremia, and the autocorrection. The chronic alcoholic man who has crackers and beer comes with confusion, sodium 114, urine osmolality 68, and urine sodium 11. Clinically mildly volume depleted, mild confused but not having a seizure. The team decides to give 2 liters of 0.9 saline for volume repletion. Patient stops drinking beer, removes the AVP stimulus, huge dilute urine output begins, and the sodium rises from 114 to 132, causing catastrophic overcorrection. This would have been the kidneys were trying to help, so even just giving gentle zero point 0.9 saline would have been enough. Okay, now too fast. Just want to talk about the first equation again, once again. The osmotic demyelination is where the sodium is corrected too rapidly, where the brain's lost organic uh, osmolytes. The sequence is rapid, chronic hyponatremia, rapid correction, and then the biphasic pattern, which we discussed earlier. The correction limits are suggested limits. The standard risk is less than 10 in first 24 hours, less than 18 in first 48 hours, and less than 8 in any subsequent 24 hours. And if the high risk is when the sodium is less than 106, if it's alcoholism, malnutrition, etc., and less than 8 we need to give in any 24-hour period. And the risk factors are all additive. Okay, so I think we'll skip this slide. So the first equation which we talked about earlier, look at the bottom part. The s- amount of sodium per liter of urine excreted is the sodium plus potassium in the urine minus the serum sodium. So this is where we need to remember how we that the urine sodium and urine potassium both are important. Let me give one example. Here, a 62-year-old woman with SIAD with cardiac cancer, and sodium is 122. Urine sodium is 85, urine potassium is 45. The first calculation says that each liter of urine worsens the serum sodium by 8 unless the urine is hypertonic relative to plasma, and therefore fluid restriction will not work here because the urine serum ratio is more than one. So where you have urea available for oral therapy in some countries available, or a vaptens can be used. In a beer potomania, to predict the autocorrection speed, you look at the serum sodium of 114, serum potassium and sodium of 22 and 11. 2 liters of urine, just imagine how much of the sodium and potassium are being lost in the urine here. So delta sodium per liter of urine is 8 plus 15 minus 114. So it's minus 91 millimoles per liter. That is, each liter of dilute urine raises the sodium by 91. And therefore, this, if you give any extra, you'll have a overcorrection. So if you have available in some countries, it's where I've used it myself in Canada. We can give DDVP subcut or IV to block the further change in the serum sodium, and then you can slowly make corrections. Okay, so the applications of this is important is where the fluid restriction will work. Second is to predict the auto correction, and the third, less important, is to monitor progress in SIAD. So here, the prediction of whether fluid restriction will work and prediction of auto correction is where we should put our money on. Okay, I think I'll just leave it. Let me one more question. The patient who has 3 months of worsening confusion, small cell carcinoma, sodium 110, duration is more than 8 weeks. Clinical euvolemic with urine sodium of 92, urine potassium of 48. The cortisol is normal, no diuretics. What went wrong is patient thought the registrar thought sodium was 110, critically low, gave 1 liter of 3% saline over 4 hours. But the sodium rises to 124 in 6 hours. This is chronic hyponatremia where the brain is adapted and the ODS risk is very high. As opposed to that, because it's only mild confusion, look at the first equation and we'll know that fluid restriction will fail because the uh, add the sodium and the urine potassium, and you will know that the first value is plus 30, and therefore the ratio is 1.27, confirms the fluid restriction failure. Therefore, where urea is available, we don't have it in a country, we can use Vaptan instead, along with fluid restriction. I think I'm running a bit out of time, so I'll just skip some of these things. The I want to talk about the dialysis patients. Now, here we have a patient. This is something which I thought we must correct as nephrologists. A patient who's got low sodium has come for dialysis. I'll show the clinical case. 60-year-old man with diabetic kidney disease, creatinine 12, who's anuric or nearly there, pilot edema, and has come with dyspnea at rest with GCS 14, serum sodium of 100, potassium of 5.8. Okay, here is where what will you do? Can you dialyze this patient? Serum sodium is only 100. So there are multiple options that we can look at. I just want to look at any of them. Can we do conservative therapy, fluid restriction, and stop offending drugs, salt tablets? Not when the patient is anuric. Hypertonic saline, yes, a little bit of correction can be done with that. Can we do hemodialysis, intermittent hemodialysis, or CRRT, peritoneal dialysis, or a combined strategy? We look at these remaining things before in the next few minutes. So the conservative measures will not work if the patient is profoundly hyponatremic, especially if oligoanuric. Hypertonic saline is important for immediate symptom relief and acute correction, but the patient with dialysis needs the dialysis to add to uh, handle the extra load. Handle the extra load. The correction, I don't have time to look through the calculations. Intermittent hemodialysis is the most effective and controlled strategy, but I'll talk about the problem and how we fixed it in our patients at the end of this. We can do CRRT for patients who are hemodynamically unstable with cardiovascular compromise, doing the same thing against the sodium of 120 in the bath of the dialysate. Can we do peritoneal dialysis? It's a little difficult, a little slower and less controlled, but it can be done for our patients as well. Or we can do a combined therapy of giving some uh, IV 3% saline, early stabilization, and then slow correction, slow volumes of dialysate, and then monitoring thereafter and seeing. Now, osmotic demyelination can happen in these patients, and therefore I want to talk about one important caveat. So here we have a patient who's got. Let me show the history first. Sodium of 100 with a creatinine of 12, who's oligoanuric. Now, even if you put a dialysate sodium of 120, lower it to 120, even if we lower it that low, when the fluid coming out is going to have a sodium of 120, which is technically much higher than what we can accept. What do we do at that stage? One of the things that we have done is to give a correction of 5% dextrose or half normal saline after the filter. That means the fluid coming out of 120 is lowered by using 5% dextrose or half normal saline, and therefore you're giving an extra volume. How do you account for this volume? Then the patient will become further volume overloaded. We remove that on ultrafiltration in the process of dialysis. So when you increase ultrafiltration to account for this water, and you're giving water post filter, I'm afraid that the sodium does not behave the way we want it to, but still it does not get the 120 rise. So this is something which we can try, as it may work. I think I'm running out a bit out of time. So yeah, so the six commandments, I found this somewhere and I copied. These are not mine. The six commandments of hyponatremia management is symptoms override everything. Therefore, severe symptoms require first treatment. Know your limits before you start. So write the 24-hour sodium ceiling in our notes before we prescribe anything. Use the first equation. This is where I count again and again. I want to emphasize, calculate the urine potassium also, not just the urine sodium. And count everything that moves sodium, potassium replacement, cortisol replacement, stopping diuretics, volume repletion, everything that changes the sodium you need to keep in your mind. And if possible, which we don't have yet, is to give have DDVP available where you can give. And overcorrection is time sensitive, and therefore this is something which we haven't discussed. If the patient's sodium is become overcorrected, what do you do? There's a lovely paper a few years ago in HAKD by doctor who was 1 year my senior in MBBS, and she's now a nephrologist in the US. In which they had a nice algorithm and description on how sodium is reduced artificially. So similar to what I was saying about the dialysis patient, if you have a serum sodium which has gone higher than what you expect, bring it down using 5% XO D5W, or half normal saline, and bring down the serum sodium to what you want it to be. Okay, so this is basically what you need to remember, and some of the numbers we need to remember is maximum correction rate in high risk is lower than standard risk, and the sodium content in 3% saline, easy to remember, it's about 50. And remember the first equation, the first value. Thank you very much for your patient listening.
Thank you, sir. Thank you. That was excellent. Excellent. Actually, it should have been a little longer. It's such a fascinating topic and such a frequently encountered and less frequently discussed. So, thank you so much for your lucid presentation. And there's a lot of take home from your presentation actually. So, Simaji, can we just move on to the panel discussion? We'll start with the questions. Just a housekeeping note, those who are interested to ask questions, please put the questions on the chat box. We'll take it up as the time permits.
Can I ask one or two questions to
Yes,
Dr.
sir. Yes, sir.
Santosh?
Yes, sir.
Yeah, Dr. Santosh, that's an amazing lecture. Really enjoyed every minute of it. I have one or two quick questions. One is the first equation that you told is a very good learner, which most people don't use when managing even chronic hyponatremia. That's an important information. The second one is you are talking about dialysis management of hyponatremia in patients who were being taken up for dialysis. I have one question here. Urea, you told, is a free osmol, so I believe that it moves freely across the cell membranes. So my understanding is that when managing hyponatremia, even if you do not strictly adhere to the correction values, the urea values in these patients being very high tend to balance out the osmotic shift significantly and reduce the risk of demyelination as such. Does
Yes,
that contribute to
Yes.
any of this?
you're right. It does. It does. Fortunately, that's how we escape with many of our patients. But then, still, when you've got a very low sodium, it's very scary. It's very scary. So something that we have been doing is to give the post dialyzer, giving them free water to try and lower the sodium a bit, trying to get a more reasonable rather than more go from 100 to 120 and hope nothing happens. See, I agree. Usually nothing happens. Thank God that nothing happens. But still, that's what we've been doing. In our thing. But I must tell you that this is not something that I've read anywhere. This is just something that just using the logic of hypernatremia correction, or we've just been implementing it occasionally. Fortunately, this happens only rarely, and we've used it. Yeah.
Right,
Yeah.
so thank
And
you.
then,
That's
so
the hallmark of an academic institute which uses all these innovative techniques in managing that. And your
yes,
lecture
yes, yes,
was full of
absolutely.
teaching students only. It was like directed at residents only completely. Amazing, sir. That's
Yeah,
a
I have
true
to admit
student.
that I used AI's help as well. I found that my slides AI was better than mine, so I borrowed
Okay.
some of the slides from AI freely. Yeah.
So let us moving to the next segment, sir. Just two quick questions to Dr. Santosh, sir. Sir, the entire hyponatremia management hinges on two things. One is the extent of sodium correction, and second, assessment of the volume status. So we need to understand that some recent cohort is now liberalizing the extent of sodium correction to almost 20 milliequivalents per day. So do you concur with it? Like, have you done it before, or would you like to add to it?
So I have okay. I'll give you an anecdote. One of my this is days before we had even the IV stand infusion pumps where you can count the bot where the counter counts the number of drops and so on. Even before that came, I was doing when I was doing my MD. My one of my colleagues was seeing some of the patients, and I was seeing some of the patients. I was going towards seeing another patient when I found one IV bottle. This was before the plastic bottles came. It was a glass bottle,
Glass bottles.
uh, and it was empty. And I looked at it and it said 3% saline. Okay, 3%
Oh,
saline. So I asked the nurse, like, when was it started? And she said it was started about 10 minutes ago. So two, three
oh,
mistakes were made. Was one, the patient was there was no there was it was not given in 100 ml boluses. The 500 ml order was written together. It was the time before where if the hand is rotated, the speed of the infusion will change. So the
yes,
patient
yes.
rotated his hand, and the infusion, which the drops which are counted, increased, and the whole 500 ml had gone in
Oh,
over some 10, I can't remember, maybe 20 minutes. It had gone in. So 500 ml of 3% saline had gone over 20 minutes. This is not a patient with kidney disease. I was internal medicine resident at that time. Normal kidney function. Thankfully, nothing happened. Thankfully, nothing happened.
okay,
So, can it be that nothing happens? Yes. Thank God in most situations. Thank God nothing happens. But the liberalization, I think we can go up to maybe 12 in the first day, or a little more than that in the first day, and then back off
okay,
after that, depending. I certainly would be a little afraid. No experience, I would be afraid of giving 20. I saw your question, so I
okay.
said 20 may be a little too much. But most people, if you use a number like 10 instead of 8, it's easier for us to
Eight.
think and understand and reason. So I think about 10. In fact, I think if I memory serves me right, the initial, the long time ago, when I was a medical student, the number used to be 10, and then it came down
Yes,
to 8. So 10 is
8.
somewhat easier, I think, but 20, no experience. Sorry, no experience at all. Yeah.
And how do you go about the volume assessment? Because we categorize hyponatremia as euvolemic, hypovolemic, and hypervolemic. But sometimes the volume assessment becomes
Yeah.
the
So
the crux of our decision making.
yeah, so I don't know clinical uh, uh, use in ICUs and all. People do look at IVC volume and so on. Um, I don't know if it's a practical thing for us to for correction of hyponatremia. Maybe in the beginning, to assess to have
Okay.
a feel where we are not sure if the patient is volume depleted and so on, it may be helpful. But things like bioimpedance and all, which people are now talking more and more, like in volume assessment, those are notoriously inaccurate in situations like cardiac failure and liver failure and so on. So in those situations we can't use it. uh, See, I think the hyponatremia need not be a very exact correction science. We just need to have our direction right and not overcorrect. That's my general understanding. Even if we are not as precise as our textbooks tell us, if our direction of correction is right, then we may be okay. That's what I personally feel. Yeah.
So, with this comment, sir, do you think the classification as hypovolemic, euvolemic, and hypovolemic has become obsolete? Like we need to talk about water restriction responsive hyponatremia, or salt responsive hyponatremia, or something like that. Means the operational definitions will take over the previous definitions. What do you
Uh,
think about it?
uh, Perhaps I haven't thought about it, perhaps, but I think the concept is that we are still thinking about it in terms of a sodium disorder, whereas it's
Yes,
mostly always a fluid
water
water
disorder.
disorder. So that, I think, is a fundamental thing. See, I'll tell you, I've made mistakes. That's why I feel very embarrassed about it. There was a patient once who had a I was I think I just finished my MD general medicine, so I have no reason to have made this mistake. I finished my MD general medicine. There's a patient who had the hyponatremia, and as I was correcting it slowly because I thought it was chronic, I was going a slow management of giving a slow correction. This patient had a seizure,
Oh,
and then my
oh,
correction became slightly more, whereas I should have given 3% saline immediately itself. So the patient was slightly, looking back, I should have given the 3% saline before the patient had seizure. So looking back, I
yeah,
did a I,
yeah.
I did something which was very, very incorrect at that stage. Perhaps it was because I didn't gauge the situation properly. Perhaps I didn't understand so much. Those may have been the reasons, but these are common mistakes that we make in clinical practice, but those are
Yes, absolutely,
definitely
absolutely.
preventable.
Right, right. That's quite perfect. Simaji, next slide, please. So the next questions is to Dr. Nagesh. So we have two questions, difficult questions reserved to Dr. Nagesh now. So the oral urea, what we were talking about up till now, is a guidelines endorsed thing. Okay, but most of the places, like even in India, we have problems in procuring the urea. So has it earned a routine place in your practice? Have you used it before, or how would you like explain it to a beginner? And the next question will be the about spontaneous water diuresis. So if we are correcting the sodium faster than the plan, uh, what's your trigger to start a 5% dextrose or vasopressin?
Yeah, good evening, everyone. Thank you, Dr. Santosh, for a very good presentations. Like it was a very excellent presentation, which covered many topics, and the first question was very good eye opener. So, coming to the question which has been given to me. So, frankly speaking, oral urea is not freely available in India, and I have not used it. But for this meeting, when I reviewed it, what I felt was that it has got many advantages, and I think it should be included in our practice. So, as we all know from the previous slides, SIADH is a disorder of water balance, not more of sodium. And then there is this inappropriate ADH secretion, which causes the inappropriate water retention. And when we use urea, it causes the osmotic diuresis, causes increased free water clearance, and there is gradual correction of the hyponatremia. It is very cost effective and is useful in patients who are having the risk of volume overload, mainly the patients with heart failure and the cirrhosis. In one meta-analysis, what they saw that it was having a consistent effect even after 1 year. Suppose you are using this product for management of chronic hyponatremia, at the end of 1 year also, it was still very effective. And also, it has got a very severity dependent effect. And suppose you have a low sodium, then it is more effective. For example, when patients were sodium of less than 120, it was given, the mean change was 18 millimoles. If the sodium was 120 to 129, the mean change was 7.87 millimole. If the sodium was 130 to 135, and when it was used, the urea was given, the mean change was around 8. So, more severe the hyponatremia, it will be more effective. So, urea can be thought about as a long term therapeutic option. The problems are poor palatability. Almost 20 to 50% of the patient complain this problem. Sometimes there can be a overshoot and can cause hypernatremia, and that can be around 18 to 15% of the patients that can happen. There is some nausea and there is some increased reflux, and that can be managed symptomatically. But the osmotic demyelination, which is the worst thing to see in our patient, is very rare with urea. And that is one of the most important aspect of the urea treatment in patients with hyponatremia. So practically, if we look at, suppose we want to start the patient on this medicine, the dose will be zero point 0.5 gram per kg. So a 60 kilo person, you can start with a 30 gram of dose, and we can expect the rise in sodium by around 7 millimoles in 8 hours. So accordingly, then you can titrate the dose. So when somebody is having chronic hyponatremia, you start with a dose of 30 gram, and you also restrict the water by to 1.5 to 2 liter, which will give you the desired effect. So the starting dose can be around 15 to 30 gram per day with 4 ounces of water, and a maintenance dose of around 15 gram per day, which can be continued. Maximum dose which can be given is around 45 to 60 gram per day.
Right.
Now, the second question which was posed to me was like when you are overcorrecting sodium faster than planned, what is the trigger? So Dr. Santosh also has elucidated in his discussion about the desmopressin clamp, which he mentioned that he used in Canada. So I think this is a very good tool in our hands, the desmopressin. So it halts the water excretion by kidney. It can be given subcutaneously or IV. The dose is around 1 to 2 microgram every 6 to 8 hourly, and it prevents the overcorrection. But these patients also need some fluid restriction when you are using this product. When you are using 5% dextrose, which is like easily available and is practically possible in every ICU, what happens is that 5% dextrose dilutes the serum sodium, and you can start with a 3 ml per kg per hour, and then this dose will reduce the sodium by around 1 milliequivalent per liter per hour, and then you can monitor the sodium more frequently, say every 8 hourly, and then once you bring down the sodium to a safe level, then you can stop it. So 5% dextrose, two quick infusions that can lead to overload, and that can be a problem in certain category of patients, like the patients with CCF or cirrhotic patients. So both the therapies can be used, and depending on the patient profile, you can use them.
Particularly in diabetic patients, we may be little hesitant to use a 5% dextrose. So,
True.
how would you negotiate in a diabetic patients where you want to prevent the overcorrection and you don't want to use a 5% dextrose? Would you go for a free water ingestion or something like that?
In routine practice, actually, this free water ingestion is practiced a lot in the neurology patients by the neurosurgeons or neurologist.
Yes.
But I
Yes.
find that it is not very effective. And many a times, ultimately, we end up using the Vaptons and then we try to do this. But I think with use of 5% dextrose and a proper management of the sugars with insulin, you can get over this problem. But I think you'll have to look up at the potassium levels more frequently also. Because by
Right.
using your insulin and dextrose, you will end up in having some hypokalemia.
Hypokalemia. Yes.
Yeah,
Yes.
so
Right.
in
Right.
desmopressin, there can be two strategies. One is a clamp strategy where you use the desmopressin proactively, and then another is the rescue or reactive strategy where you use the desmopressin when you find that something happening and then you use it. So 1 to 2 microgram of desmopressin can be given, and then you start the patient on 5% dextrose, and then you titrate the dextrose dose and help to control the sodium.
Absolutely.
Especially in patients who have this hypernatremia, I thought this Madias equation works very well, and I would like to ask Dr. Santosh what is his experience in case of hypernatremia, how he look at this use of the equation to correct the sodium level.
Dr. Santosh sir, are you there?
I'm actually in opinion of the patient. But can I bail out of answering that question? The patients are in front of me.
No,
Yeah,
no
like
problem, sir. No.
Please,
as you
please don't mind.
said, like sir, yeah. So anybody's
Yeah.
opinion, like the panel, other members.
Shrikant sir?
Yeah. So my experience with hypernatremia is very little, but I just want to add one more thing to what Dr. Nagesh has explained. Dr. Nagesh has beautifully explained the difference between DDAVP and D5W, but for us here, we don't have IV or subcutaneous desmopressin available. We use only that nasal spray.
Nasal.
Each puff
Yeah,
is approximately equal to 1 microgram. That's what we presume.
yeah,
One
yeah.
thing is the difference between the two is one is desmopressin, it stops aqueresis, whereas D5 water, it corrects the already created problem. Like for example, if you have overcorrected, you can correct it by dextrose, But if you are
Mm.
worried about severe accuracies, like what sir is talking, Dr. Santosh was talking a little while ago about how certain patients are at high risk for a spontaneous rapid correction. If that is
Mm.
the concern, or if the concern is about patients who are likely to have a osmotic demyelination by view of their premorbidities, severe
Mm.
malnutrition, alcoholic liver disease, cirrhosis, these patients should be treated with desmopressin first, and then your sodium correction can go, and you can use all the formulas in the world to predict what
Yes,
is likely to happen to the sodium, and they are likely to work very well when you are using a desmopressin. It locks
absolutely.
everything up, so whatever you give is the one which is going to correct it.
So my
Yes,
question to
absolutely.
you will be, in which patients you use desmopressin proactively?
Yeah, this is what I was saying, sir. For patients who are at very high risk for osmotic demyelination, and
Mm.
patients who are suddenly showing a diuresis, suddenly their urine output has dramatically increased, the urine has become very dilute, 1 liter of, 200, 300 ml every hour, I'll be worried about rapid correction. Those are the patients whom I would preemptively give a desmopressin nasal spray,
Yes.
and then continue
Okay.
to correct it.
I
Okay.
think that
Great.
word preemptive is very important
Yeah.
because you're not waiting till we get the symptoms and then start working. The preemptive word, I think that's very very important here. So coming
Correct.
back to Shrikant sir, see, when the onset is genuinely unknown, does symptom severity override and ambiguous timeline in setting correction speed? Because many a times we don't have a baseline sodium available, we don't know how much time has elapsed since the symptoms have started. So how you deal with this ambiguous timeline in hyponatremia management?
Okay, so I think Dr. Varghese has already answered this question partially. There are two things here. One is the seizure risk. So
Yeah.
when you are managing hyponatremia, the first 30 minutes of correction, which is meant to mitigate the neurological risk, it has to be rapid. It has to be done within 4 to 6 hours. But then once the first 4 hours, or first major risk is you have corrected it, say from 110 to 114, then you have averted a significant risk of seizures. And after that, the correction can be slow. So what I would do is to correct the initial part very aggressively, but after that, if I don't know the timelines, I would definitely manage it as a chronic hyponatremia.
Okay. So most of the places you'll consider it as a chronic hyponatremia and try to avoid an overcorrection. That is the take home from your your point.
Yeah,
So the
I would
last
say,
question is, uh, see, when you are correcting the cause, like a thiazide diuretic induced or something like a diuretic induced hyponatremia, where does furosemide earn a place as a treatment rather than the cause, like alongside the hypertonic saline or to permit fluid liberalization? So we just need to understand, where does furosemide stand in management of hyponatremia?
yeah, so that's a see, the difference between thiazides as a diuretic versus furosemide is about the medullary osmotic gradient. So furosemides do not maintain that, so they cause free water loss. So theoretically, they should be good drugs when managing hyponatremia because they cause a significant free water loss. But when it comes to the most common cause of SIADH, of hyponatremia, the SIADH, the free water loss cannot happen because the overwhelming stimulus of ADH. So it does not really play a major role there. But when you are managing hyponatremia, which is hypervolemic, say diuretic, say chronic liver disease, congestive heart failure, or a nephrotic state, those are the patients in whom you want to get rid of that excess water. That is the situation where furosemide can be safely used, presuming at least it does not worsen the hyponatremia. Other than that, I think this standard SIDH, I do not really use furosemide for the management of hyponatremia. I don't know if there
When
are
you are
any other
using a,
opinions regarding this.
yeah, Dr. Nagesh, you can comment on this, the last question.
Yeah.
Where does the furosemide stand in the management of hyponatremia? That was the discussion ongoing.
I feel कि after the availability of laptons, we really have reduced the use of fuel cement. Like I don't remember I have used this
I think
because again
hypervolemic
it can cause
hyponatremia,
some
sir, is
sodium
one
loss
situation.
and then
In hypervolemic
yeah,
hypernatremia.
but then it is yeah, but then you do not have the controls there actually, like what is happening. Many times
So
we see that these patients will have developed the hyponatremia again.
in some patients who don't respond to fluid restriction, I think there has been some role to furosemide. So the hypothesis that it's going to blunt the medullary osmotic gradient by blocking your sodium potassium to chloride channel, and hence it's going to reduce the it's going to improve the sodium by reducing that medullary osmolality.
Yeah, so it increases free water excretion, yes. Yeah, in one way it may
Yes.
allow you to liberalize a little more fluid intake in these patients. In chronic hyponatremia, in whom you have to strictly adhere to the fluid restriction. They're not able to do it. Probably you can use it as an add-on to liberalize a little fluid intake, because it will anyway cause free water diuresis in the kidney.
So I think that's where we come to the conclusion of this webinar. It's such a common topic that we discussed, and it has become such interesting because we came to know some equations. We came to know which are the patients who will respond after water restriction, who will not respond after water restriction. What is the role of potassium in the management of hyponatremia? So I believe we need to have two or more webinars on hyponatremia as a topic again. So with this, I actually thank everyone. I thank Dr. Santosh Varghese sir. I thank Dr. Shrikant Gundlapalli sir. I thank Dr. Nagesh Agor sir. And on behalf of all of us at Nephrocon, Dr. Manan, Dr. Saurabh, Dr. Purva, and Dr. Suhas, uh, please take care and a good night to you all. Thank you so much.
Can I
Thank you.
put one final
Thank
comment,
you.
Dr. Girish?
Yes, 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 sir. Yes,
Yeah,
sir.
somebody has asked in the chat about article mentioning hypernatremia corrections. I think this is directed to Dr. Santosh Varghese sir. And one thing I would say is there will be the 2013 landmark article, which first time told
Yes.
that initial rapid correction should be there. Is a beautiful article about hyponatremia correction. The second thing is probably I thought that the whole webinar is built around this 2021 Brazilian trial, where they have noted that the osmotic demyelination is a very, very rare syndrome compared to. Yeah, Dr. Santosh.
किडनी का फंक्शन ओके है किडनी का फंक्शन ओके है एक किडनी बोल रहे थे आप 20
So
Yeah.
that was, I think, Ayush Arif syndrome. That was the word coined in that article, which told us about rapid correction of hyponatremia to prevent non-cardiogenic pulmonary edema. So I think that was one thing that has changed our understanding of treating hyponatremia rapidly. So I mean, this was the cartoon very aptly tells us that we need not be too slow, we need not be too fast, but just right in treatment of hyponatremia. So I think that was a wonderful, wonderful answer. Thank you so much. Seemaji, can we conclude here?
Yes, so we will just go offline now. I think.
Okay.
Yes, sir.
Yeah. Thank you, everyone. Thank you so much, and have a good night. Thank you.
Thank you, Dr. Girish, for the
Thank you.
Thank you, sir. Thank you, sir. Thank you, sir.